Thank you very much, and thanks to the organizing committee for the invitation. So I'm going to share with you a pivotal trial in neuroendocrine cancer. We've been fortunate in neuroendocrine cancer to be basically the launch site for most of the radioligand therapy that has emerged, and its radioligand therapy has completely transformed the field of neuroendocrine cancer. These are my disclosures. So the first trial, I'm sure many people are aware, but the first radioligand therapy trial that was done was at a large scale, like this was the NETTER-2 trial. This trial showed patients who had small bowel neuroendocrine cancer who had progressed on standard therapy, which at the time was somatostatin analogs. They were then randomized to receive Lutathera, 4 cycles concurrently with somatostatin analogs versus a high dose of somatostatin analogs. This was a groundbreaking trial published in the New England Journal of Medicine by Dr. Strasberg, and was the first trial that led to an approval of a commercially available radioligand therapy. You could see here that there was clearly a benefit in progression-free survival to the lutetium-177 Lutathera arm versus the standard arm, with a modest response rate of 18%. Oops, pardon me. In the meantime, we've also similarly, in a very similar population, now had completion of the COMPETE trial done by ITM with a compound we'll call ITM-11. This was a very similar patient group, except that it was a bit wider, that it included pancreatic neuroendocrine tumors, as well as it had a small proportion of patients who were treatment naive, about 15%. Patients were then randomized to receive ITM-11. Key difference is it did not require concurrent somatostatin analogs, which is very convenient from both the provider and a patient point of view, and its dosing is every 3 months versus every 8 weeks. The comparator arm was everolimus, a little bit more of an active comparator, you could say. And these are the results that have been released so far. We await for the complete publication, but the initial results show a benefit of median PFS from 23.9 months to 14.1 months, with a response rate of 22%. Now, these are generally in slow-growing neuroendocrine tumors, and between these two trials, this has led to the point where Lutathera, or soon-to-be ITM-11, will become standard part of our treatment algorithm for neuroendocrine tumors. The next trial that we did was the NETTER-2 trial, and this was published in Lancet about 1.5 years ago. This looked at high-grade neuroendocrine tumors, and it showed that, well, in those patients who seem to have slower-growing neuroendocrine tumors, after somatostatin analogs, radioligand therapy appears to be quite beneficial. What if we do it first line? And this was the first trial done that showed first-line therapy with radioligand therapy, again, opening up a brand new door. So in the world of neuroendocrine cancers, we divide it into well-differentiated and poorly differentiated disease. In the well-differentiated disease, we have grade 1 and grade 2, but as a 2017 WHO pathology reclassification occurred, there was a new category of patients called grade 3 well-differentiated neuroendocrine tumors, and there was no optimal treatment pathway described for them. So this was a patient group where we did not know what the optimal treatment pathway would do, who had aggressive disease. This led to the design of the NETTER-2 clinical trial, which looked at patients, 226 patients globally who had advanced SSTR-positive disease. They had what we call grade 2 or high grade 2 or grade 3 disease based on something called the Ki-67, which is a proliferation index, between 10 and 55%. Patients were newly diagnosed. They had to have been diagnosed within 6 months to be enrolled on the trial and had not received any prior therapy. They were then randomized to receive first-line Lutathera, again concurrently with SSA, versus high-dose SSA, which was the control arm in the NETTER-1 trial as well. There was a retreatment arm as well as a dosimetry arm, but I won't go into those details today. When we looked at patients who were enrolled on the trial globally, you could see we had a fairly wide mix of patients. About 50% of patients were from the pancreas origin, which indicates the more aggressive types of neuroendocrine tumors that arise. They generally arise from the pancreas, but we had small intestine as well as others. When you look at sort of what we call the Ki-67 index, it was between 17 and 16%. So a fairly indicative of a fairly aggressive population in need of therapy to hopefully improve their outcomes. In most systemic therapy trials, we talk about dose intensity. It's harder to do that when we do design a radioligand therapy trial because we don't reduce the dose. These doses come standard. So we look at the number of cycles that was delivered. 88% of patients received all 4 cycles of treatment, indicating tolerance of the compound. Finally, this was the endpoint, the progression-free survival. As you could see here, there was a significant hazard ratio of 0.28, indicating a 72% reduction in the risk of disease progression or death with patients who received first-line Lutathera. The median PFS was improved from 8.5 months on standard therapy to 22.8 months. And I should indicate just generally, both in the NETTER-1 trial, the NETTER-2 trial, and all the other trials, if this was breast cancer or one of the larger groups, this would be quite an achievement. We don't see hazard ratios of this. This would be on the front page of the New York Times and things like that. Because this is a smaller tumor group, it hasn't received quite maybe the same notoriety that would be expected. But I just want to indicate for those people who aren't aware, this is fairly significant results in the oncology world. When we looked at the subgroup analysis, this is a non-multivariate analysis, but the univariate analysis, it was fairly uniform, as you could see here, throughout all the subgroups, whether age, race, tumor grade, or the site of tumor origin. The main thing is these patients had to be SSTR positive. So it only included patients who were SSTR positive. Obviously, we wouldn't want to use this therapy in those patients who are not SSTR positive. When we looked at the response rate, this was I would say, a pleasant surprise. I don't think many people were expecting this high response rate when we initially designed the trial. This showed, a response rate of 43%. And at this point, as a trial, and now we have alpha therapies coming forward, but at this trial, this is the highest response rate we've seen in RLT to date. And in fact, in all neuroendocrine cancers, we hadn't seen response rates of this high to date. When we looked at safety, in fact, fairly well tolerated on a daily basis. In fact, some of the things we would expect, like nausea and diarrhea, was actually higher in the control arm than on the experimental arm with radioligand therapy. At the time of publication, we did have one case of MDS, which continues to be followed closely. We now have 2 cases, which kind of goes in line with the 1% to 2% that we quote patients in their first line. There was some episodes of small intestinal obstruction. Again, these were aggressive patients. Some of them had high volume of peritoneal disease. So it's something that I think opens the door to us thinking about, A, are the patients with heavy peritoneal burden appropriate for radioligand therapy? And B, are there modifying things that we can do to potentially change that? So given the results of this, it was fairly profound knowing that both we can not only stop the tumor from growing, but potentially shrink it in almost half the cases. So we wanted to try to understand what was driving. Is there a certain group of patients? Was it the pancreas or the small bowel that was driving this effect? Or was it the grade 2s or the more aggressive grade 3s? So we did a multivariate subgroup analysis. And it showed here fairly uniform results, whether they were grade 2 or grade 3. The effect of radioligand therapy appeared to be fairly uniform on these high-grade patients. And when we looked at those patients who had either pancreatic or small intestine NETs, again, we seem to see a fairly uniform benefit, indicating that it really was more the aggressive disease that appeared to be the factor rather than any of these subgroups. When we looked at the response rates, we continued to see fairly high response rates in both the grade 2 and grade 3, as well as the pancreas. The response rate was slightly lower in the small intestine neuroendocrine tumors, and that's likely due to the idea that, as I mentioned, the pancreas neuroendocrine tumors have a slightly faster pace of growth versus the small intestine tumors. Although these were all high grade, probably weren't as aggressive as the pancreas, but still 27% response rate is much higher than what we saw in previous trials. So that has led to us to really introduce Lutathera earlier and earlier on in terms of the treatment algorithm. And as I mentioned, we now have other agents coming through in neuroendocrine, such as ITM11 and potentially RAISE101 and an alpha compound coming through. The results of that trial will be available later this year. We also have the results of the COMPOSE trial, which is very similar to the NETTER-2 trial, but compares it to chemotherapy. And that will be a pivotal trial. I think what NETTER-2 showed us is that RLT works very well for high-grade neuroendocrine tumors. What we want to find out now is how well does it work compared to traditional chemotherapy. So that will be a pivotal trial for us as well. Again, with this idea of moving RLT earlier and earlier into the treatment algorithm, I think there was some thought previously that we would want to save it, and I think that is sort of, these studies are helping us understand that, you don't hold back Sidney Crosby till the overtime period. You play him in the first period when you have a game. So we want to start to use our better agents earlier and earlier, and that's led to the design of the NETTER-3 trial, which is recruiting right now and we have open. This is looking at first-line Lutathera or RLT in those patients who have lower grade disease but have bulky disease, so i.e. things that we predict will get them in trouble. This is things like lesions greater than 4 centimeters, primary mesenteric disease in place. It's left to the investigator's discretion, but it has a number of guidelines around this, and this now randomizes people to the Lutathera arm versus standard somatostatin analogs. Inevitably, this will be a positive trial. I guess the question we're going to have to decide is how positive does it need to be for us to be starting to think about really moving this into first line in low-grade patients? Are there select groups of patients that we would want to use this in first line? And what is the safety considerations in terms of MDS and other risks? As I mentioned, we have the actinium trial coming forward. This is a new compound as well that is being looked at currently, RAISE 401. This is another actinium compound, which many people are probably familiar with. The big thing about this is not only is it alpha therapy, but it reduces the need for amino acid co-infusion. Currently, that's about a 5 to 6 hour endeavor. At our center, we give it in the systemic therapy unit. So not having to give systemic amino acids would be a game changer. This would make this much more along the lines of what we think in Pluvicto, et cetera. The other areas that are continue to be explored include retreatment with PRT. So we've hopefully shown that in neuroendocrine cancer, PRT is a very important agent to improve the outcome and the quality of life of our patients. So if we give 4 cycles, can we give more for those patients? A couple of trials going forward. We're leading from the CCTG, a North American trial run through the NCI. So this is quite exciting for us here in Canada. This is the first GI trial that the CCTG is leading throughout all of North America through the NCI, looking at retreatment. This is a phase 2 trial that compares patients who received 3 or 4 cycles of Lutathera and had a good response. And by good response, we've defined that as 12 months of stability. They're then randomized to receive 2 additional cycles of Lutathera versus the standard therapies, which could either be Afinitor, i.e. everolimus, cabozantinib, or sunitinib. As I mentioned, the other retreatment trial that's important is the Action 1 trial. We had this open here as well at Sunnybrook, and we were fortunate enough to be the global co-head of this trial. This trial will report out hopefully this fall, it looks like. This is another retreatment trial, but in this case it uses actinium. So alpha therapy instead of beta-beta, it goes beta-alpha. A key difference here is the degree of stability here was 6 months. So the way I sort of view this is that the actinium trial looks at non-resistant populations, i.e. patients who had at least 6 months of stability, whereas the retreatment trial that I talked to you about initially is really about good responders or long responders. So I think both of these trials will be very important for us to understand not only the efficacy but the safety of retreatment with radioligand therapy. And then there's ways to potentially think about improving radioligand therapy. How do we deliver it? I talked to you about the difference between Lutathera and ITM-11, one key difference being not having to take concurrent somatostatin analogs. In most principles of oncology, once a treatment stops working, we stop it. Somatostatin analogs have been somewhat of an exception to that rule, and I'm not completely sure we have the data to support that. So this is a small trial being done on a feasibility between Australia, Canada, and New Zealand through something called the COMNETS initiative, which is looking at, called StopNet, which is looking at stopping the somatostatin analogs for patients who are receiving standard of care radioligand therapy. There's also a large trial being done in the Nordic countries called the Sauna trial that's looking at this similar, and one arm is the PRT. So with that, thanks very much for the invitations and happy to take questions. Yeah.